Hi, I'm recording right now in between my open skills lab and the rest of my life. Actually, I'm taking a little break right now, so here we go. I'm going to do the last 4 lectures right now. Nurses' duty is to adhere to legal and ethical principles, and you know that. I went round and round, and you've learned that before anyway. So again, we are responsible to the patient. We must respond, and we're responsible to also our colleagues and the hospital, and we're accountable for all of those entities as well and more. We must respond to the patient and again treat the patient both within their legal and rights and within our ethical and moral principles. We are responsible to educate the patient. We must comply with standards of care. We are to supervise care. Remember that RN carries the weight of supervision and looking to make sure we can properly delegate to others. We must adhere to the nursing process. That we know the nursing process. We develop the data collection and planning when there's a problem, and we're the RNs are the ones that construct all of that. We follow up as required, meaning we follow up on a lot of things to what the patient's needs are. We follow up in terms of delegation, and we're on top of things. We develop and maintain a good interpersonal relationship with the patient, the family, and we also have the responsibility to do that with our colleagues and people that we are delegating to. And we must also document carefully. So just kind of a synopsis of what we do and what we must do in terms of adhering to legal and ethical principles. The last few slides deal with documentation specifically, so let's go there. Next slide. Documentation dues. Next 2 slides are going to be all dues. We must document in a timely manner. If we don't get to documenting an incident at that time, we know that in electronic documentation, it automatically will populate up to the current time that you're at. So you will have to go ahead and document exactly what time and look at the individual programs to do that. We must know the standards and be able to document according to those. So standards of care, what does that mean in terms of the standards we practice in the different settings? What does and they're all going to be different from hospital to hospital and unit to unit. They have taken the standards and they've modified them according to the population of patients you're taking care of. We have to have legible when we're writing something, and that does happen. We're still writing some things, and we have to convey messages that way. If we do, it must be legible. It must be full, accurate, objective descriptions without our subjective influences whatsoever. You can't go and write something about, well, the patient said, or the patient was unhappy about the way things were done. You have to go ahead and use subjective patient statements to support things like that. You can't write your own subjective ideas or thoughts. The next column talks about chart your senses, sight, hearing, touch. Use discretion with these, and smell. So what that means is to go ahead and chart everything you see. And really I always say this, and you'll hear this from me probably more than once, about painting a picture with your words. What exactly do you see? What are you hearing? Describe those. What might you be feeling? And using discretion here with your psych patients, you're probably not going to be touching them too much, but you might be. And so we want to look and see, if it warrants touching. Now, somebody with a sprained ankle or some musculoskeletal type issues, you're going to really want to touch that and feel that, but you need to get permission from the patient and what have you, especially in our setting right now. When you go to med surg, you're going to be touching people all over the place to really get a good sense of what's happening with them. And what do you smell? And that is really important. Our patients here in the psych setting come in rather odorific, and malodorous is what we call. You don't want to use odorific, but malodorous, and you don't have to go, they smelled icky. That's not what you want to put. You want to put malodorous. So anyway, anything that you use your senses to describe things and describe them so that when somebody else reads it with they can actually get that same feeling and that same sense of what's happening and perhaps walk into the room and get that same feedback that you just described. Complete your assessments in the time allocated. So if it's an admission assessment, it says it has to be done within 8 hours of arrival to the unit. It has to be done within 8 hours of arrival. A good note to do is to think about documenting real priority assessments right away, getting those in at the same time that you get your vital signs in. If you're on the day shift, in any shift, that's going to be within the first 2 hours of your shift. Usually on the day shift, doctors arrive around 9 o'clock, or others that are interested in vital signs and current assessments, especially on the things that are really problematic, they're going to want to see those when they arrive. So if you make it a principle for yourself to document those assessments and vital signs, anything necessary you want to convey to somebody else that might be looking for that in the chart, get it done in the first 2 hours. Okay, next slide. Make sure you document pertinent observations, behaviors, physical symptoms, really, really important here, especially on our units, the behaviors and any changes that you see. We tend to, in psych and the providers there, the nurses there, may overlook some of the physical things that are going on. Very, very important to do that, because we know that there are profound side effects with medications. And there have been instances where people have smuggled things in and ingested things that they shouldn't have, and they're having physical symptoms that people are looking at and just looking the other way and saying, oh, they're just too sleepy today, or they're not going to come out of their room, they're isolating, when in fact they're having some real physical issues. Document on any unresolved problems. You want to always document on those, but once they're resolved, resolve them and no longer document on them. That will waste your time. Document all you do, everything you do. Every time you walk into a patient's room and you do something with that patient, you need to have it documented. Vital signs, obviously, you're going to record those on a vital sign graph. But anytime you come in there and teach a patient anything, talk about, help them out of bed, to go do something, you have to document everything. Patient's subjective response is not yours. I already went over that. Chart any discharge instructions that you gave, and then also chart that the patient understood that. Now, they don't have a little meter that pops off the top of their head that says, geez, I understand now. You have to ask them specific questions. You have to evaluate appropriately their understanding. So you want to document that they restated to you the side effects of those medications and when to take that medication, or whatever you think is very important for that in terms of teaching. The next column says you need to document when you notify the MD or clinician. That could be psychologist, somebody of you're trying to get some information across, and of course you're going to use SBAR when you talk to them, and you're going to document the time that you spoke and any responses you got from them. If they did not come by to see the patient, then or call you back, you have to document incrementally after that. Maybe 30 minutes later, still place another phone call, still no call back. Document all of that, because if you want to make sure that you're really saving yourself on that one, because somebody can dispute that. What time the patient was visited, definitely go ahead and do that. And you're only going to document facts surrounding unusual occurrences, and you're going to make sure you put that in the appropriate documentation. Facts around unusual occurrences, for instance, the patient falls. Patient fell, doctor notified, but there would be an unusual occurrence form that would put all the details into that. And that's where somebody would be able to find that information. Next slide. And last slide. Okay, what you don't document. You do not document an incident that has been filed. The hospital, that's hospital privileged communication. So if the patient fell, doctor was notified, that's all you put in your own documentation on that, and then you would go ahead and document that the You wouldn't say when an incident report or an unusual occurrence report was filled out, you would go ahead and do that separately. Do not chart your own opinions. Do not defame or use derogatory statements. And do not erase, which you won't, but backspace and erase. A lot of the electronic record formats will not allow you to do that. Obliterate, leave anything blank if using pen or paper form for documentation, especially you can't do that. But you'd have to follow the guidelines on the electronic documentation. Okay, I think that's it for you. Have a nice weekend if you're listening to this prior to the weekend. Bye.